Hello, everyone. Good evening and welcome to ICPA Clinical Series. Yet another episode. This is the 16th episode, and ICPA Clinical Series solves one clinical challenge in each episode. So far, we have completed 15 episodes, and today we have a special occasion. Today is 27th of July, and this is World Head and Neck Cancer Day. And keeping the theme in mind, we have invited one of the very well-known maxillofacial prosthodontists in India who is on a unique mission to change the landscape of maxillofacial rehabilitation in India, because head and neck cancer rehabilitation is one of the biggest unmet needs of cancer patients in India. And the speaker of today, a visionary, he thinks that the solution to many of these problems lies with general dentists. And we have with us Dr. B. Srinivasan, a prosthodontist from GDC Mumbai. He was my batchmate. He finished his MDS from GDC, and then he worked in Tata Hospital, Tata Cancer Hospital in Mumbai. Then he went to Netherlands twice for higher education in maxillofacial prosthodontics. He came back and he started his venture in Pune. He created a unique team where he, as the prosthodontist, joined hands with speech therapist, general surgeon, ENT surgeon, plastic surgeon. Together, they are creating a variety of solutions whereby they can uplift and enhance the quality of life of cancer patients. So, the word enhance suits gels very well with what he's doing, and his mission or his venture enhance head and neck rehabilitation is a center of excellence for head and neck cancer rehabilitation and oncology dentistry. And Srinivasan and I thought we should be coining a new word for this session, and we came up with this word called as oncodentistry. I don't know whether we are the first people to coin this word. Must have been there in use for quite some time, but the title of today's lecture is Oncodentistry, which can create a lot of potential, lot of opportunities for practicing dentists. So let me introduce Dr. Srinivasan, what he's currently doing. He's the chief executive and of Enhanced Head and Neck Rehabilitation. He is also the consultant for Reliance Hospital Mumbai, Ruby Hall Cancer Center Pune. He's also the managing trustee for Enhanced Social Initiative, and he's the vice president of International Society for Maxillofacial Rehabilitation. And if I remember correctly, he has also contributed one of his cases to Bumer's textbook on maxillofacial rehabilitation. It's a matter of pride for all of us. So without wasting much time, I take the privilege of inviting Dr. Srinivasan to take over and start his lecture. Thank you.
Yeah. Thank you, Rajiv, for a very generous and kind introduction. I just hope that the slides are visible to everyone around. So please confirm the same.
Visible.
So are you able to see my slides, Rajiv?
Yeah, we can
Yeah.
see.
Yeah, sure. So thanks again, Rajiv, for a very generous introduction and setting the ball rolling. And what a better or rather auspicious occasion than the World Head and Neck Day could we have chosen to introduce oncodentistry, to the entire community. And I'm reasonably sure that it's an exceptionally promising branch and can definitely add a new dimension to everyone's practice. So, for starters, head and neck cancer can be very, very unforgiving, with the cure more dreadful than the disease itself. We can very clearly see that in this particular photograph that this lady refuses to look into the camera for the photograph, which clearly indicates that there is a very severe loss of self-esteem. But she's not alone in this entire. There are millions and millions of her like hers globally, and patients like her are invisible in the population. And a lot of them face physical disability, emotional distress. They're financially stretched because of their primary care, and eventually end up with a suboptimal quality of life. And you can the statistics are staggering, and the disability that ensues after the surgeries that these people undergo. are impaired speech, swallowing, appearance, chewing, productivity because of all the above disabilities, and all these significantly affect their mental health. Now, this is where the opportunity lies, because for all of us, and for dentists to make a real big impact in society, because less than 50% have any kind of access to rehabilitation. This is as per some of the reports, but in my own experience over the past 20 years as a clinician in this particular field, I've realized that hardly 10% actually, especially in our country, have any kind of access to rehabilitation or end up getting rehabilitated at the end of the day. So there is a huge opportunity uh, for general dentists to get into this near virgin field and create a very, very big impact. Now, the solution for all, the entire issue is going to be achieved by shifting the goalpost in care. Gone are the days where people can work in isolation, and the new era in healthcare is going to be surrounded by multidisciplinary approaches, where reconstruction and rehabilitation would be planned even prior to surgery and need to be part of the workflow. And if that does not happen, the results are always going to be suboptimal, as they have been for so many years in the past. So technically and traditionally, at least in dentistry, aesthetic dentistry and dental implantology, the glitz and the glam that surround all of them, have been historically overshadowing the true impact that a general dentist can make in society. And this is definitely a very wonderful opportunity to make amends. So let's start our progress in this presentation with a short video, which will actually set the ball rolling on the real unmet need, and that all of us are need to fill in. And I call this the forgotten patient, because somewhere deep down, all of us have completely forgotten about these patients. So a lot of these patients survive the disease but are unable to cope up with the aftermath. You can see that as the patient progresses through cancer care, sometimes he ends up getting deteriorated. So this is a very genuine plea, a shout to the entire society by all these patients. Was it really worth surviving? Friends, let's do something for them. So, what are the biggest problems that these patients encounter due to the defects arising from from cancer surgeries? Result in suboptimal speech, swallowing, appearance, depression, chewing, loss of productivity, as I've already mentioned earlier. So, prosthetic reconstruction and rehabilitation definitely does restore these lost functions and and leads to a more optimal quality of life. But does a general dentist really have a role to play in this entire spectrum of treatment? We shall soon find out. So the types of cases that a prosthodontist like me would routinely encounter are treatment of maxillectomy defects using an obturator, use of implants, prosthetics for mandibular defects, lies with plastic reconstructive surgeons for a fibular reconstruction, facial prosthesis, eye, ear, nose, etc. But you also have other issues that a lot of these patients face: mucositis, trismus, irradiation caries, need for dental extractions, poor oral hygiene, and a conservative treatment sometimes where root canal treatment or endodontic interventions can can be used as a substitute for aggressive extractions. Now, who is going to do all these types of interventions? The general dentist, of course. Now, some facts. If you feel that this is not these are not huge numbers, let me tell you that the incidence of head and neck cancers in India is about 500,000 year on year. And based on 20 years of my experience, what I have really realized is that about 30% of head and neck cancer patients need prosthetics, but almost 100% of head and neck cancer patients need oncodentistry. And that is where you and each one of you who is watching this particular presentation can step in and add immense value to each of these patients and create an enormous impact for these patients and also in society. Yes, 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 and yes. Dentists definitely do have a role to play in head and neck oncology. Some quick situations where you may need some interventions. One of the most one of the pillars of head and neck oncology treatment is radiation therapy. Always and probably, I wouldn't say always, very often required as an adjuvant treatment modality after cancer surgery. But one of the acute side effects of radiation therapy is mucositis, and it is one of the most clinically significant side effects. Its frequency and severity limit the aggressiveness of therapy and may interrupt or preclude the completion of therapy in some case situations. There have been instances where patients stop radiation therapy simply because they are unable to handle mucositis. So there is palliation is one of the most is the of symptoms is the best possible approach, and a general dentist can definitely aid in this. So during the management of mucositis is also a field of intense study. So those who are keen on the research aspects of dentistry also have a wonderful topic to address. Now, the radiation also creates backscatter, and a lot of our patients may have metallic restorations in their mouth, and in the form of crowns. Now, if you have backscatter from any of these crowns, you can end up with localized mucositis, radiation mucositis, which can be localized in the vicinity of such restorations. Now, a simple thing of creating something like a coverage similar to a night guard and just pushing the mucosa away from the metallic restoration can be very, very useful to this particular patient in reducing the incidence of localized mucositis. Now, some of the late effects: telangiectasia. Now, and scarring and fibrosis of the lamina propria, and also telangiectasia can be an important indicator of how the patient has actually responded to radiation therapy. So, and if you observe telangiectasia, you know that the oral mucosa can be easily traumatized or perforated. These ulcerations that develop after that are very slow to heal, and because of the reduced vascularity and fibrosis. Now, if as a general dentist who can peep into the oral cavity and due to the knowledge of the oral anatomy and physiology, is well placed to address these kinds of situations, and if any kind of prosthetic interventions are actually required, these can be a general dentist with knowledge of these kinds of situations will be able to handle them much better. Trismus is one of the biggest bane of radiation therapy, and a lot of patients with a reasonable mouth opening of about 25 to 30 millimeters pre-radiation therapy severely end up with severe trismus, leading to mouth opening sometimes as less as 5 to 10 millimeters during the course and after radiation therapy. So a general dentist can definitely step in very, very quickly and train the patient with oral physiotherapy using certain well-known protocols, and ensure that the patient does not reach the stage of trismus. And if the mouth opening is adequate, oral hygiene can definitely be easily maintained by such patients. Now, the radiation therapy, especially when it affects the major salivary glands, is going to result in xerostomia, reduction in IgE levels, change in the oral microflora, and results with irradiation caries. Now, timely intervention by the general dentist can definitely help these kinds of patients and prevent a lot of these kinds of clinical situations, as I'm showing on the screen now, from arising in the first place. Now, what is the role of pre-radiation extraction in the prevention of osteoradionecrosis? Selected tooth removal prior to radiation therapy is extremely important and very often missed by the oncology team. Now, especially mandibular molars in the field demonstrating a furcation involvement, for example, will significantly reduce the rate of osteoradionecrosis and reduce the risk of a patient developing a discontinuity defect secondary to ORN. Now, newer advancements in radiation therapy definitely have reduced the risk of or the incidence of osteoradionecrosis over the years. But having said that, any kind of early extraction is all prior to radiation therapy, especially of hopeless teeth, is always going to be very, very useful to such a pool of patients. And why is pre-radiation extractions important? Because it has been proven that ORN secondary to pre-radiation extractions is less than 10%. And even if there is any kind of ORN, they can very often be treated by conservative means. Whereas ORN secondary to post-radiation extraction can lead to more extensive infection and leading to loss of major segments of the mandible. So a general dentist definitely has a very important role in the oncology team by effecting these pre-radiation extractions, especially those of hopeless teeth. Now, dental maintenance. We all know the effect of fluoride in the role of fluorides for prevention of decay. Now, this becomes even more important in patients who are undergoing radiation therapy. Again, who else can do this but a general dentist? So, topical fluoride applications, hygiene instructions, and a regular follow-up using employing dental prophylaxis once every 3 to 4 months is going to stand the patients in good stead. Sleepy already? Wake up, because the real exciting part is yet to come. So if you look at post radiation extractions, especially in patients who did not get the opportunity, there are certain rules and regulations that need to be followed as part of protocols in trying to in the decision making whether to effect post radiation extractions or not, where and how to decide between endodontic therapy versus extraction, the choice of materials in restorative dentistry. All these are going to be based on the side effects of radiation therapy and what radiation does and how it changes the entire dynamics in the oral cavity. So there is nothing new that a general dentist really needs that he needs to learn when it comes to extractions, endodontic therapy, or restorative dentistry. All that he needs to understand is the effect of radiation therapy in the oral environment, and he can use his existing skill sets to treat such patients in need. So most periodontal procedures predispose the patient to a great risk of perforation of the epithelial attachment and therefore osteoradionecrosis, and hence are ill-advised in this patient population. Now, even if you are looking at doing crowns, for example, in such patients, you'd rather have the finish lines supragingival rather than going equi or subgingival and warranting any kind of gingival retraction. So, if we were to look at implants, any implants can be inserted in patients with minimal risk if the radiation dosage is 5,500 centigrade and below, which means that all you need to know is that most of y'all are trained with the dental implants. So all you need to know is the effect of radiation therapy on bone, and how it changes over time. And by with just knowledge of the kind of radiation that was given to the patient, you can very clearly understand whether a dental implants can in fact be used in such patients or not. And the use of dental implants, especially in patients with the defects, can be a very useful adjunct for retention or anchoring of prosthesis. So what is oncology dentistry at the end of the day? It is just using your existing skills in a very challenging situation and leading to the oral rehabilitation of a patient in need. So what we are essentially doing here is using almost 80% of your existing skill sets, maybe 10% of training, and another 10% of application of this newfound knowledge, to be able to create a wonderful impact in an entirely new pool of patients. And this is going to definitely enhance your practice in days to come, because the number of oral cancer patients in our country is rising by the day. So as I mentioned, there are a good number of types of cases that we can already address by use of prosthetic reconstruction. Now you can replace the upper jaw, the lower jaw, eye, ear, nose, etc. And the most significant addition to this entire process is going to be the use of technology. Now, a lot of you have heard about teeth in a day. Have you heard of jaw and teeth in a day? And that's something which is achievable today, and that can be done wherein you can replace both the half of the jaw, for example, in this particular situation, and the teeth all on the same day. Does it need any additional skill sets? You know how to place your implants. All you need to know is to understand the is to integrate your digital technology. You know how to do your prosthetics in your day-to-day practice. All you need to do is extrapolate that in a slightly different environment. So it is definitely possible, and each one of you, with a bit more of application of your existing knowledge, can definitely treat these patients as well. Now, you need not, with the advent of digital technology and the wonders that digital technology has to offer, you need not have the patients in front of you anymore. Now, when I completed my masters, until a few years back, if I had to do an auricular prosthesis or an ear prosthesis, I had to call the patients to my clinic. I had to make impressions, sculpt the entire ear in wax, go through the entire laborious laboratory work, mix the silicon, and then and again fix it on to the patient, either with an adhesive or using implants. But then we realized over a period of time that a lot of patients were not able to access care simply because of geographical distances. And that's where we embarked upon a project with support from BIRAC, the government of India, and we developed a unique protocol wherein we can treat patients remotely. So you, as a general dentist, need not learn the entire process anymore. All you need to know is to tweak the colors of so that you can if you have attended a basic drawing or art class during your school, then, and if you have a basic knowledge of colors, all you need to do is to tweak the color of the prosthesis, and you can apply the adhesive and stick on the prosthesis over the defect, just as you would apply like a band-aid or an adhesive bandage. It's the entire process has become so very simplified over the years, which means starting tomorrow, if you see a patient with a missing ear, nose, or an eye, you need not feel that you cannot help that particular patient. You are definitely going to be able to help such a patient, because we are in a much better situation today to be able to support you with using digital technology. So the time has now come where even a general dentist can start treating such patients immediately. So the use of prosthetics is now changing from by leaps and bounds. So today our mantra is give us a digital scan from anywhere in the world and we will courier you a prosthesis. Doesn't it sound disruptive? So all you need today is probably a mobile phone on a CT scan. Mobile phone use of the mobile phone is still in an experimental stage. We've already created prototypes, but what's already being done routinely from our side today is the use of a CT scan and convert that into an artificial part of the face or a facial prosthesis. You can see how the workflow entire works and how it can make a difference to the patient's face. We'll go through this particular case in greater detail in a couple of minutes from now. So this was about a lady who is from Kashmir, and then she had a bare mole injury. It was not cancer. It was an injury, but you can definitely extrapolate this kind of a defect in oncologic settings as well. So she was working in the field when a bear attacked her from nowhere and took away half of the face. And it was difficult for her to get rehabilitated in her immediate vicinity. And neither could I, sitting in Pune, treat her, go all the way to Kashmir to be able to treat her. So this is going to be her story and how we were able to treat her. Believe me, in times to come, each one of you will be able to treat patients like this because of digital technology. So the challenge was, how do we treat her? So just getting a bit more into her history and the background situation, she had an extensive midfacial defect post-healing. The losses were obvious. A major chunk of the upper lip, nose, portion of the zygoma on the left side, and almost 90% of her palate. And the problems that she was facing were pretty much obvious: severely compromised aesthetics, difficulty with articulation, mastication, swallowing, and an enormous loss of self-esteem. So the data that was acquired was by a CT scan, because as I mentioned, the use of the mobile phone as a scanning device is still in its experimental stages. So we used a CT scan because that was very easily available in her vicinity. So using the scan that we got, we immediately imported that into a CAD software, and then we created a prototype for her upper jaw prosthesis. So the acrylic was 3D printed, the clasps were 3D printed, and based on some basic assumptions and principles of prosthetic dentistry, we kept the trial of her prosthesis ready. Now, the moment the implants had to be done there, so my good friend Dr. Sankalp Mittal, he placed the implants for her there, and then once they were healed, that's when we started the entire prosthetic intervention remotely. So we have not, believe me, we have not seen the patient at all. We created this entire prototype without seeing the patient. So I have not seen the patient at all. The first time when I see the patient is when I try the obturator prosthesis. It needed a few tweaks, but the skeleton was already ready, and this we were able to tweak it in a couple of minutes. And then it went on for a process of acrylization, and then that was the prosthesis in situ. But because we had the prosthesis already mapped digitally, we were able to keep it ready, and that formed the basis for her facial prosthesis. So the moment we inserted the obturator, the difference in speech was evident. This was without. This was with. And the moment she wore the obturator, it was the first time that she could hear herself speak with reasonable intelligibility for a good 1 year, ever since the accident. Now, because we had the prototype of the entire maxillary prosthesis already done virtually, we were able to fabricate the facial prosthesis as well, and we kept it ready even before we saw her. And through a series of processes, we kept the silicone prosthesis ready. So mind you, we have kept the entire prosthesis ready, and we have still not seen the patient. So once we tweaked the maxillary prosthesis, all we had to do was to fit the facial prosthesis. Now, as a general dentist, if you encounter such a patient, the first thing tomorrow in the morning, the first thing you should say is, I will do it. Why? I will address the needs of such a patient. Why? Because you know that we are there to support you, at least in the initial stages. All you need to do is to learn to tweak the prosthesis and be able to fit the way it is shown in this particular picture. And you are suddenly going to be a facilitator to change the life of a patient forever. So this was the CAD workflow, and this was the entire journey from a defect to which was unsightly to something which is more acceptable to the eye. Now, this entire journey has also of our treatment has been mapped in a short video which I would like to share with you.
डिवाइस के जो चेहरा था, चेहरे की भी रंगत आ गई है और वही पुरानी तरीके से देख रही है और 2-3-4 दिन हो गए लगभग वो खा पा भी रही है अच्छे तरीके से.
Now, if you were to encounter a patient like this as well, he's a patient who had an extensive cheek defect secondary to radiation therapy. He was located 400 kilometers away, unable to reach us because of geographic distances. He was alone, and all that we needed as a result was a CT scan. We kept we used a combination of CAD and 3D printing, kept the prosthesis ready, and his entire defect was managed remotely. And all that was shared with us was a photograph of his and a CT scan. So if you were to encounter a patient like this tomorrow, all you need is to take some good photographs, ask the patient to go for a CT scan, and we will be there to support you to treat such a patient. Now, we are extending the remote healthcare delivery program beyond facial prosthesis, and we are slowly making inroads into intraoral defects as well. Mind you, this is going to be a bit tougher than the facial prosthesis, but we've had some initial successes, and it sounds very, very promising. So if you have an intraoral defect tomorrow as well, especially for patients with defects, it is going to be and if you feel that you're not really up to it in trying to make this extensive defect, make impressions of these extensive defects, I think we can definitely help you out in trying to by finding out some digital solutions so that we can create prototypes that will help you make your entire clinical process easier to handle. Now, as I mentioned, this was a case where the patient was located in Sydney, and then we had to treat this patient remotely. And again, we got digital scans from Sydney. We converted this entire process using a combination of CAD and 3D printing, did the color matching using photographs, and then shipped it across to Sydney, after which I jumped onto a Zoom call and then supervised the fit over video conferencing. So it's all possible today with the advent of digital technology. So what are the advantages? There is no need for patients to travel anymore. It's the data that is going to travel and over the internet. There can be online interactions with the clinicians, and in a central hub, through the central hub in Pune, we will be able to support clinicians anywhere in the world in times to come, making patients and doctors' location completely agnostic. So what we are attempting to do is a ready to treat solution, and using the Amazon principle, uh, we are very soon going to be promoting data from home and treatment in your neighborhood, which means the patients can get their scans done in the comfort of their home, and you as a general dentist can facilitate fixing of these prostheses for them right there in their neighborhood. So this is going to be completely disruptive, and you are going to be playing a very important role in this. So digital technology in times to come is going to make treatment more predictable and reproducible. Dentists by inherently are very much inclined towards the use of digital technology. So this is not going to be very difficult, but of course with a bit of training. Make remote healthcare delivery a reality, and make rehabilitation scalable to reach the masses. So the next steps from here on for each one of you is train, tweak, and treat, which means tomorrow, if you're going to be able to get a patient with this very basic information, if you have some idea, and if you feel that you would be able to treat, I think we will definitely be able to guide you through the next steps, so that whatever you've heard today can be put to immediate use tomorrow. A good starting point could be, if you feel that you're lost, a good starting point could be refer to us and learn through those initial cases, because come early 2023, and we are going to start with some training programs wherein you can structure your entire learning process, and then start putting it into use into your daily clinical practice. And then we will help you to reach out to the oncosurgeons in your vicinity, so that you can avail the patients can avail of your services right in their own city, and need not travel all the way to Pune out here. That is definitely a part of our vision. We don't want patients to travel very, very far in pursuit of care. We will definitely help you to create the awareness, and we very strongly believe that this is going to take your practice to an entirely new pool of patients, and help you enhance your practice in times to come. So friends, let's join hands, be a part of this a completely new paradigm shift in head and neck oncology care. Use implant dentistry, cosmetic dentistry, and your existing skills, and make that transformation into oncodentistry. I look forward to interacting with each one of you in times to come, and using this wonderful opportunity of World Head and Neck Day. I would like to make this. I would like to exhort each one of you to participate in this entirely new exciting venture, and I'm sure that together we can definitely make a difference to all these patients in times to come. Thanks to you, Rajiv and ICPA, for giving this wonderful opportunity today to share my views with all of you. I would be very happy to take some questions if there are any. Thank you for a very,
Thank
very
you.
patient listening.
Thank you, Srinivasan. This was an amazing lecture, and looking at the possibilities, looking at the acute need that we have. As you said, there are about 5 lakh patients every year of
Yes,
head and neck cancer, and
yes,
so many of them undergoing chemotherapy, radiotherapy, and surgical excision, because of which they'll be having a lot of surgical defects as well as the complications of the treatments.
absolutely.
Like you showed, dry mouth, oral mucositis, irradiation caries, and so many other things for which a lot of them will be requiring daily care, daily support in the form of pharmacological prescriptions. And then the other half is improving their quality of life through reconstruction, maxillofacial rehabilitation. So
Yes,
you showed both the aspects where it could be plain prescription, and also it could be maxillofacial rehabilitation. And The old times are gone where the patient had to travel all over, to the place of rehabilitation and get it done. And now you people are able to do it digitally. So you could create a prosthesis and send it to a patient sitting in Australia, and you could monitor it over a camera. That was an amazing thing. I just wanted to know more about this BIRAC fund that you said that you
Hmm.
people that you and your team won. So what was it exactly? If you can tell more about it.
Yeah, for sure. So, in as part of the Make in India program, what the government of India has done is through BIRAC, which is the Biotechnology Industrial Research Association Council. That's the full form of BIRAC. They give proof of concept grants. So, which means for any person who wants, they don't support PhD research or academic research leading to publications. They are supporting research leading to commercialization, which means they are going to support you with funds and funding if you are willing to innovate on the use of technology and come out with a product or a service which can be commercialized outside.
Okay.
So you need the best thing to do is to form a multidisciplinary team, because that gives them the requisite confidence that you will be able to they'll be complementing skill sets, and then you have to pitch. Coincidentally, you have the next grant. I think it closes on the 15th of August. So for those who are interested, they can visit the BIRAC website, BIRAC BIRAC, and they can apply for what is the biotechnology ignition grant. So
Okay.
at least you can go through the information there, and that's a starting point. It's called a proof of concept grant, which and the grant amount is reasonable. It's up to a maximum of about 50 lakhs for the team,
Okay.
and you
So
get
there
about
are
18 months to prove your concept.
okay. Okay. So there are some questions which I'm taking. I'll be taking one live question and one from people who had already registered and they have sent. Okay.
Sure.
So here is the question: what does a team that addresses such cases typically comprise of?
Hmm. Okay.
So I
So
mean, somebody wants to know if this doctor in his or her own city wants to start addressing these cases, then it may not be a job of one person, and even they have to build a team. So if they have to
correct.
build a team, what that team should be of?
Right. So there are you can divide the entire team into the ones which are involved in primary care and the ones which are involved in rehabilitation. The patient would generally reach the oncosurgeon first. So it would be either a surgical oncologist, it could be an ENT surgeon, it could be a maxillofacial surgeon, or it could be a general surgeon. Generally, the patients would first reach the oncosurgeon if they suspect cancer. Now, once the diagnosis is made, sometimes as an add-on to surgical intervention, you may need a radiation as well as chemotherapy. So that's where you need either a medical oncologist and or a radiation oncologist to be a part of the team. And when it comes to reconstruction of the defects, it is going to be a plastic reconstructive surgeon and a maxillofacial prosthodontist who should be working in tandem for reconstruction. And then last but not the least, the pillar of the entire process is going to be the general dentist, in my opinion, because they are going to be taking care of all the side effects of radiation therapy and aftercare. And so this is going to be, in a nutshell, the team. You also need to be having a nutritionist, a psychologist, a physiotherapist, and a lymphedema specialist as well. Did I mention speech and swallowing? So speech and swallowing therapist as well. So that would comprise the entire team, 360 degrees. But unfortunately, the vast majority in our country are you don't have all these people as part of the team even today, and that's where we need to step in.
So how are we going to solve these problems? So suppose somebody from a rural area, as I can see, somebody from a rural place in India has written here.
Hmm.
If this is not possible for the place where she is practicing,
Hmm.
what is that minimum team she should be building? Or she should just
So
refer to you?
yeah, I mean, for starters, see, change cannot happen overnight. So we can definitely help and support and facilitate in the initial days, but it's going to be an ongoing process. So the first couple of cases, or the first couple of months or weeks, somebody who's staying in a rural area and does not have either the know-how or the infrastructure can probably start with the referral, simply because it's going to at least create the awareness in their immediate vicinity about the possibility of such kind of treatments. And as I mentioned, our mission is to train the general dentist and being able to take care of these of troubleshooting and smaller issues to start with. So the first thing that they can do is refer, learn through the initial cases, as they say, learning on the job, and then over a period of time get enrolled into a training program which is going to help structure their thoughts, and they will become the leaders in their pioneers in their rural area, or torch bearers in their area, to initiate rehabilitation. It's a step by step process that they will have to take on. It's not going to happen overnight, but yes, we can definitely help facilitate that for them.
So the first thing that I understand is people should build awareness in their own area that
Yes.
they are ready to treat such patients.
Yes.
Cancer hospitals are there in very few cities, but cancer patients are there in every city and every village. So
Absolutely.
dental practitioners who are practicing in those cities where there is no cancer hospital should spread awareness that even though they are dentists, they can play a big role in supporting and improving the quality of life of these cancer patients.
Right. So, in
And
fact, an
yeah,
interesting anecdote out here is, there was an article in the British Journal of Oral Maxillofacial Surgery a couple of years back, wherein they said that the choice of reconstruction depended on the availability of a prosthodontist in the vicinity. You know,
okay, okay,
what it actually means, when you extrapolate, is if you don't have a dentist sticking out his neck out to the oncology team in their vicinity and says, hey, listen, I'm there to take care of the oral needs of your patient, most of the oncosurgeons or this thing are forced to send the patients away because they don't have anybody in the vicinity who is willing to treat such patients. So, which means that the moment you have somebody, even in a rural place, going to the nearest oncology center and telling them that, listen, they are available to treat such patients, I'm reasonably sure that patients will start trickling in.
okay. So people can, general dentists can make use of their own website, their own social media accounts, and start putting out messages, and
Yes,
even make their existing patients aware that even this service is available. And at the same time, they can be in touch with you, be in touch with Enhance, and start getting either some virtual counseling. And if somebody is looking for reconstruction, they can directly take some impressions. So whatever that workflow can be decided upon later. So for that, what we have done is we have created a Google form. I think in all the chats I have put it on Facebook and YouTube. It is called I'll just read out the URL: bit.ly/ enhance ICPA. Enhance ICPA is the slug. Okay, so you can use the same form, the form which you have filled before attending this lecture. You can use the same form and you can write your query there, how you can take your next step. So the first baby step, we have, Dr. Srinivasan has already told: build awareness around your practice, and then referral consultation. Enhance is already there. And the third most important step is when Enhance will introduce their course where people can get trained and they can start giving the services. I think these are the three steps, if I've understood it correct.
absolutely, absolutely, Rajiv, bang on. And but in fact, each of these, you always need a poster case in your vicinity to showcase. So your first case can always be, can go a long way in trying to build that much needed awareness in your vicinity. So you're absolutely right.
Okay, okay. So I'll just take another a few more questions. How
Sure.
are the finances? How are the finances for the treatment? Is the cost too high for restoration?
Cost is a very, very relative term. I think what we should generally be speaking about is value. Uh, we all know the costs of implants, how their costs are. So I think they are going to be these are like full mouth, like a full mouth rehabilitation in short. So the cost can always be brought down. Cost is is very subjective, and especially one of the reasons that we are trying to create a network of, or rather, we will be creating a network of with all of you, is that once the volume of patients increases, the cost will automatically go down, and that is
Correct.
the mission. That is the vision that we have, to bring down the costs drastically for the patients.
Okay. I think there is a question from a periodontist. Can scaling be done post radiation and post chemotherapy? Because oral hygiene is compromised and there is calculus accumulation which may be subgingival. It necessitates subgingival debridement and removal of subgingival calculus. So you mentioned in your talk that perio procedure should be deferred. So what is your opinion?
Ideally, yes. So I would say I would always advocate perio-related procedures pre-radiation, and that's again where the general dentist and periodontist would step in trying to educate their oncology colleagues in their vicinity, that these kinds of patients go through any kind of perio interventions pre-radiation rather than post-radiation. There's always
Okay.
going to be a risk, and at any point in time, we have to evaluate the risk versus benefit in trying to take that decision whether to intervene or not. But yes, I do stand to my ground to suggest that these scaling and related perio procedures are better done pre-radiation than post-radiation.
And of course, if somebody is a heavy calculus prone, heavy calculus
Yes,
accumulator, we can always prescribe pyrophosphate based toothpastes, which can
yes,
control new
you
calculus
can
buildup to a great extent.
restrict your removal of calculus to the supragingival area to start with, and then see how the patient is doing with the other side effects of radiation therapy. For example, as I mentioned, telangiectasia. If you can get those initial signals, whether how severe the oral reactions were, how the tissues have reacted to radiation therapy, and then start taking that call.
Okay, okay. And may I ask, what has been your experience with the use of saliva substitutes in dry mouth? How good have they been in improving the quality of life of these patients?
Um, there are a lot of salivary substitutes available in the market, but by and large, what works best for most patients is carrying a small bottle of water along with them, and taking small sips of water from time to time, because I've seen that not many patients are able to afford these salivary substitutes on a regular basis. So they are good, but eventually, what works for practically on the ground for most patients is a bottle of water, from time to time. Yes, so if you have a product tomorrow coming into the market which is going to be address the affordability issues as well, then I think it will be more easily acceptable by vast majority of patients.
Okay, okay.
India happens to be a very price sensitive market for
Yeah,
everything.
yeah, yeah. There is a question from a prosthodontist.
Sure.
How to and where to get medical grade silicone if I want to start it?
Yeah, medical grade silicone, you can visit factor2.com or Technovent, which is UK based, and Factor2 is US based. You can definitely visit their websites and just swipe your credit card, and you can order silicone from there directly.
Okay, okay. Uh, I think most of the questions have been addressed, because all of them wanted to see how they can be a part of this mission and how early and through what steps they can build oncodentistry practice in their clinic. And you
Hmm.
have given them three clear steps. Should maxillary defects be closed using grafts by oncosurgeons? Are there any indications for the same?
Yes, maxillary defects are always there is always a debate in oncologic circles whether the defects should be closed with prosthesis or with free flaps. Now, with the newer advances in free flaps, I think there's a growing tendency for the use of flaps. But having said that, you need to replace the dentition. So a prosthodontist is never going to be out of business, irrespective of whether it's going to be treated prosthetically or using a flap. There are very
Okay.
clear algorithms in literature, if you refer to, and where there are guidelines to suggest when you should use a prosthesis and when you should use a flap, or when you can use either of them. So I think those algorithms are already existing in literature.
Okay. I don't know how relevant this question is. Prior to starting rehabilitation
Hmm.
in oral cancer
Hmm.
treated cases,
Hmm.
do you make use of any screening methods or tests to ensure that there is no secondary cancer or second recurrence of the cancer time to time?
Uh, Sorry. By and large, no, practically. But most of these patients, at least, end up for rehabilitation after the first, after the first year. The vast majority of them, because by the time they come to us, the oncosurgeon has already suggested a PET scan, and has already made an attempt to monitor any kind of recurrence. So the oncosurgeon has already done that in a vast majority of situations. But having said that, if that is not done, I wouldn't go out of my way to screen for recurrence,
Okay.
as long as it is if I'm going for something which involves extensive implant surgery, then yes, or extensive surgeries, then yes, I would go for a PET scan, or consult my oncosurgeon and radiation oncologist as well. But otherwise, by and large, I do not really go for any kind of screening.
So
It's generally it's already
in
done.
short,
It's already done.
yeah. So in short, if you already have an oncosurgeon in your team,
Hmm.
he will be playing that role to check the existing condition, if there are any new growths and all those things.
Absolutely. So there is
So
always continuous monitoring, and
yeah.
no matter what, there can be a recurrence or metastasis anytime. We are generally talking about 30 to 40% 5-year survival rate of oral cancer. So we try our best to rehabilitate patients so that they can enjoy a reasonable quality of life. So
Okay.
the prognosis of the particular case is always ascertained before choosing the plan of action for reconstruction or rehabilitation. So, for example,
Okay.
if you feel that the prognosis is not very good, which I would first discuss with the entire oncology team, then I would go for more conservative kind of interventions for rehabilitation than being very aggressive with it in terms of use of implants and otherwise.
Okay. Okay. So for all people who have joined late, please check the chat. Please check the chat. There is a link bit.ly/enhance ICPA. This is the Google form. Make use of the Google form. Write your question, how you want to enter after listening to the lecture, what ideas you have got, and what your questions are regarding how you want to initiate yourself for your practice into maxillofacial rehabilitation. I'll take the last question now. This is a dentist who has opened a laboratory. He has started a lab. He has created a lab setup for maxillofacial rehabilitation. Now he
Nice.
wants to know what new thing he should do, how he should start. I have started a laboratory setup for maxillofacial processes. I am another passionate dentist trying to make a difference in the society, but I am unable to scale up in terms of patients and in terms of awareness regarding these defects. How will you be able to help me? I think this is a very, very specific question.
Yeah, I think we definitely need a good, passionate technician if we want to scale up the impact as well. So I think we should definitely catch up. We should try to exchange our ideas in terms of scalability, and I think we should definitely team up, because we are constantly looking for people who share the same vision.
So Srinivasan, what I will do is he has already given his contact details. He has given his WhatsApp number and his email ID. I'll share
Sure,
those contact details with you and let us
sure,
see how we can take it forward.
absolutely.
So that pretty much ends all the questions, and we have had a great session, and so many things which we used to think unachievable just a few years ago have been made possible, achievable, thanks to the passion and grit Dr. Srinivasan has shown, the kind of team he has built, and the consistency with which he has taken the science forward, and also the way he has been making use of the technology, the advent of technology, and how he has incorporated in his practice and giving the patients, even those who are located in remote places, giving them rehabilitation and improved quality of life. So I thank Dr. Srinivasan from the bottom of my heart, and I think the purpose of observing Head and Neck Cancer Day on July 27th is more than fulfilled, and we are extremely happy, privileged, and proud to be a part of this cause. And I wish you all the best. And since we have initiated a new Google form and it is already there in the circulation, let us hope to get more and more dentists, even general practitioners, come up with their specific queries, how they want to initiate. And today we have enumerated three steps: improve awareness, improve delegation, and then get trained. Those three steps we'll describe in greater detail. And as Dr. Srinivasan said, 2023, a brand new and properly built training program will be on. So that time you can always come down to Mumbai, Pune, get trained, and go back and build your own team, no matter which place of India you are in. So thank you, Dr. Srinivasan. Thank you for being with us. Thank you for sharing your cases. And for those who missed the live lecture, you will be getting a 5 point summary of this lecture in the next 2 days with the link to the recorded lecture. So if your friends have missed, please tell them that there is a recorded link available. You can share that link with them, because this is not just a lecture, but it's the beginning of a long mission, a long journey, and we want more and more people to join and be a part of this mission. So
As
that
a
brings, yeah,
as a as
please.
a as a as a, as a closing this thing, Rajiv, I just want to take a small chapter out of the Ramayana. Hanuman himself did not know what his potential was, and it needed a Jamvant to actually tell him what he can achieve. So if this entire presentation is acting as a Jamvant, and if we are able to make the general dentist as extrapolate the sketch of Hanuman to all our dentist colleagues, I think this presentation is well worth its time and effort.
Thank you. Thank you so much. So that ends today's session, the 16th episode of ICPA Clinical Series. Each episode, one clinical challenge. Soon we'll be coming up with our 17th episode, and the information will be out on social media. So once again, thank you, Dr. Srinivasan. Good luck and all
Thank
the
you,
best to
Rajiv.
you, and best wishes to Enhance and its future endeavors. Thank you
Thank you,
so much.
Rajiv. Thank you, ICPA, for this wonderful opportunity.
Thank you. Good night. Good night,
Good night.
everybody.
Good night, everyone.